Hi, everyone. Thank you so much for joining us today. This is Erin Robinson from the Center for the Study of Social Policy, and we'll be getting started in about 5 minutes.
Good afternoon and good morning to those of you joining us from the West Coast. I'm Ngozi Lawal, Project Director of Prenatal to 3 Initiatives here at the Center for the Study of Social Policy in Washington, D.C. I am so pleased to be welcoming Cristina Novoa, Senior Policy Analyst from the Center for the American Progress, to speak with us today about a report she co-authored. The report, Eliminating Racial Disparities in Maternal and Infant Mortality, was just released earlier this summer. And when I came across the report, I thought it made sense to include this topic in our webinar series. This body of work that we're helping to support through the generous support of the Pritzker Foundation under the National Collaborative of Infants and Toddlers has 3 pillars that we look to in terms of helping children get ready for school and be ready to succeed, to be successful by the time they're 3 so that they are ready for kindergarten. And this seemed like a timely topic. So I'd like to welcome Cristina and ask Cristina to speak with us for a little while to talk about some of the highlights of the report and to talk about implications. And then we'd like to open it up for questions from the audience. You may, as audience representatives, you may type your question in during the presentation. If you think of a question you'd like to pose to Cristina and just can't wait until we get to Q&A, or you may wait until we get to Q&A and indicate to us that you'd like to be unmuted, and then we will unmute you and you may speak with Cristina. So Cristina, welcome, and thank you so much for being with us today.
Great. Thank you so much, Ngozi. And thank you to all of you for joining us today. I know that this is the lead up to a long weekend, and so I really appreciate getting a chance to speak with you all about this important work. I want to take a moment to introduce the Center for American Progress and to give you a little bit of research, a little bit of background on my amazing co-authors who helped me with this report. So CAP is a multi-issue think tank here in Washington, D.C. that houses diverse policy teams, including early childhood, which is my team, health team, women's health and rights, poverty, economic policy, and a number of other social issues. And because of this, I think we're really uniquely positioned to address a topic as complicated and multifaceted as racial disparities in maternal and infant health. And again, you'll notice that I'm talking about racial disparities in maternal and infant health. These are 2 closely related topics that unfortunately I think are just treated as separate. So as Ngozi said earlier this spring, in May 2019, CAP released a comprehensive policy agenda to eliminate racial disparities in maternal and infant mortality. And this is the culmination of about 18 months of work, primarily between the early childhood team and the women's health team, in consultation with other policy teams here at CAP. I want to take a moment now to thank my co-authors, especially Katie Ham and Jamila Taylor. So about 2 years ago, they proposed this new body of work across a number of CAP teams, and their leadership has just been absolutely instrumental in getting this work off the ground. So very early on, about 2 years ago, we started to do some preliminary research to determine where exactly our focus should be. And based on the available data, we decided to focus especially on disparities in outcomes, in health outcomes, between white and African American women and infants. And there's a couple reasons behind this. One, those are the largest and the most consistent gaps in health outcomes that we saw. And these outcomes persist even when you are controlling for demographics. So even when you're controlling for income and education, you still see poor outcomes for African American women, sadly. And 2, simply there's just more research on these gaps, why they exist, where they're most severe, and so on. But I'm saying all of this is because even though we're focusing especially on disparities between African American and white women, we want to recognize that there are other inequities out there that are just simply getting less attention, often because the groups in question are just smaller and collecting high quality data is trickier. So you see that this is especially the case with Native Americans, who make up only about 2% of the population, but you're also seeing that this is potentially an issue for subgroups of Asian Americans and Latinx communities, especially Afro-Latinas. So in the interest of time, I'll be primarily focusing on racial disparities between Black and white women, but I think, of course, there's much more to be done thinking through other disparities between groups. And I encourage you to look at some of the other work that CAP has done on these topics, and please check out our report. So I'm hoping to keep my discussion relatively brief in order to give us the most time possible to discuss how we move ahead. I'm also going to try to focus on policies or changes in practice that can be implemented at more local levels. I know that you are all leaders in your community, and so I'm hoping to be able to direct my comments more towards things that can actually be implemented by you all. And so I'm hoping to identify specific policies that we've come across that can eliminate racial disparities in maternal and infant mortality, focusing specifically on some of the great work that we've come across at the level of states and local communities taking action. And you'll see as I go through this, I'm going to try to keep this very high level so we can continue to talk more and have more discussion in the second half of the presentation. And you'll also see that a lot of these policy solutions that we'll be discussing don't fit neatly into any one bucket or any one box. They cut across several policy areas and several policy recommendations. So although it seems like we're talking a lot about health equity and health inequities lately, it's important to note that this is not at all a new phenomenon. The United States has been home to an inequitable health outcomes from the very beginning of our history, or at least as far back as our data go. So from a national or an historic perspective, health outcomes have been unequal in the United States from the very beginning. But also from an individual life course perspective, health outcomes are also unequal from the very start of life. We see health disparities start even before birth and during pregnancy. So in general, African American women are more likely to experience a preterm birth or low weight birth. Sadly, they are more likely to lose an infant before its first birthday, and during their pregnancy, they're twice as likely to experience severe maternal morbidity or a dangerous, life-threatening complication, and they're 3 to 4 times more likely to die from pregnancy-related complications. And importantly, you still see that these disparities hold even when you hold things like income and education into account. There was a recent finding from from 2016 showing that African American women with college degrees are still more likely to experience severe complications than white women who never graduated from high school. And you see a similar pattern on other outcomes like infant mortality. So again, this is a really bleak picture, but sadly, it's not the whole picture. We see similar patterns for Native American women, some Latinx and Asian communities, but again, they're just not as consistent across outcomes. But again, we're focusing here a lot on African American women, but this is not the only group that's affected by these inequities. So I also want to take a minute now early on to define some terms that I'm going to be using throughout the discussion. These are a couple closely related terms, but I think it's really important to help us establish a baseline so we can have a more fruitful conversation in the future. So first is this concept of disparity. A disparity is essentially just a difference between groups in a particular outcome, whether that's a health outcome like infant mortality, or it's an educational outcome like school readiness. This is kind of a value neutral term. It doesn't say anything about whether these differences are fair or unfair, or what gave rise to these differences. In contrast, inequities are disparities with greater context around them. Unequal social and economic conditions are what give rise to these disparities that we're observing. The good news, though, is that these inequities are avoidable, and they can and they must be changed. Social policies are really what helped get us here, what helped drive these inequities, and so social policies are going to be a crucial part of helping us undo this damage and dig ourselves out of the situation in which we find ourselves. So I want to give a quick overview. Many of you might be familiar with this, but to tie it into sort of the broader context of what's happening here. So I want to do a quick overview of how unequal conditions are across the lifespan and the negative consequences of these unfair and unequitable conditions last throughout the lifespan if children don't receive extra support from other protective factors in order to balance out this damage. So some research shows African American babies receive worse quality care in neonatal intensive care units compared to white babies. And without proper support in the form of early intervention and supportive family and so on, this has the potential to affect them across the lifespan. So this is in the hospital. When they go home from the hospital, African American families are offered fewer adequate housing options than white families, and they're more likely to live in substandard housing with environmental toxins such as lead throughout childhood and adolescence and into adulthood as well. Throughout school, they're more likely to be suspended or expelled than their white female peers for similar behaviors. And once they enter the workforce, African American women earn only about 63 cents for every dollar that earned by white men. And they're also more likely to work in jobs that lack the structural supports that they need, including paid sick leave and paid family leave. So we see all of these systematic social economic inequities really get under the skin, causing fundamentally different life trajectories. And when the stress that these inequities cause are inflicted during sensitive developmental periods, like infancy, this can have especially harmful effects. But that's not the entire picture. In addition to that, these social and economic forces of institutional racism across the lifespans increase the wear and tear on African American women's bodies. And it's not just racism, it's institutional racism and sexism as well. This has long-term consequences for their health and the health of their future children. This idea has gained a lot of traction over the last couple of years, and it's built on this idea of the weathering hypothesis by Arlene Geronimus and the life course perspective from Michael Liu and Neil Halfon. So this gives you a little bit of background on where we're coming from, our read of the literature, our understanding of the lay of the land, in order to help us get our facts straight and see where do we go from here. We've admired the problem. What can we do to actually fix it? So our idea is that based on our read of the literature, our idea is that the experience of racism and sexism across the lifespan contributes to poor health outcomes that we're seeing when women are ready to start families. And again, we're including physical and mental health in this vision. And we argue that racism, not race itself, is what's leading to health disparities. So you're seeing all of these health disparities sort of from the very beginning. But problems in healthcare institutions deepen the inequities that already exist. So given that this context, our idea was to work in tandem. We want to address problems in healthcare now, while also trying to correct for more upstream problems in order to help ensure that women and children are entering pregnancy and entering parenthood healthy, ready to start a family, and setting themselves up for the best chance of success and a healthy future. So these are broad areas, broad policy areas with many specific suggestions under each one. In the interest of time, of course, I won't be able to go into all of them, and I'll focus on specific examples of interest, especially in local communities. If you have any questions about any of these, I encourage you to review our full report. And CAP also put out a number of additional projects in the year and a half prior to the report's release that take deeper dives into many of these, including healthcare, nutrition, and so on. So I'm going to start with the first one. Absolutely critical to improving health outcomes is improving access to critical health services. Healthcare access, including prenatal and postpartum care, is absolutely essential to women's health. We know that healthy babies start with healthy women, which means that when women can manage chronic conditions like diabetes, high blood pressure, any mental health challenges that they may have, and so on, the odds that they'll have a healthy pregnancy improve. But to date, too many women still lack access to the services that they need to stay healthy before, during, between, and after pregnancies. The Affordable Care Act has seen big improvements in women's access to these critical healthcare services. So at a very minimum, it's absolutely important that policymakers preserve these gains and continue to expand women's access to healthcare, including comprehensive reproductive health care. In addition to that, we also see there's recent reports showing that too many women lack access to maternity care and live in what are called maternity care deserts, where they have no or limited access to obstetric care and to midwifery. So, of course, these are mainly things that the federal government is responsible for, and happily we've seen some improvements in these areas, and also some threats. But this is something that is sort of the domain of federal government. Luckily, there's still plenty that local communities can do by helping families navigate healthcare settings in order to help them ensure that they get the care that they need. So as many of you know, healthcare system is often complicated. Women and their families often lack information about what services are available. It's unclear what services are available. It's unclear what additional supports can help them get access the care that they need. Just being able to simply get transportation to make their prenatal care appointments is a significant challenge for some communities. And so local communities can do much more on helping families navigate this complicated healthcare system. In addition to that, women also lack the resources to develop and advocate for birth plans that fit their needs. And again, this is another need that these community-based programs help address for women. There are a lot of community-based programs that we have come across in our research that help connect families with additional support systems. Lots that I could talk about, but I just want to highlight a few. These are all community-based organizations founded, staffed, and led by women of color throughout the country. The first is Mama Toto Village here in Washington, D.C., that we had the good fortune of being able to visit. The second is the JJ Way in Central Florida. The third is Ancient Songs Doulas in New York. So these programs are all unique. The great thing about them is that they're able to be really tailored to fit the unique needs of the community. But they all, in our research, have a couple things in common. One, they really try to meet the unique needs of families, connect families with resources that are available in the community, including nutrition assistance and housing assistance. They also help pregnant people learn about alternatives to hospital-based births. So this could be a birthing center, or this could be a home birth. They also connect pregnant people with additional supportive health providers. So, for example, doulas, midwives, and other birth workers. And these individuals can help provide support to women, help them advocate for a birth plan that works for them and that meets their needs. And they also provide parental education and support around things like breastfeeding assistance, childbirth education, and so on. So what can policymakers do? if your community has programs like this, continue to support them. Continue to support them through grants that help them develop the education and training programs that they need to serve the families. And also help them develop ways, engage them in ways to better integrate doulas, midwives, and other birth workers and birth professionals into birth settings. So moving on, once you're actually helping women get services, a next step is ensuring that the care they do receive is high quality and respectful. We know that this is a serious issue with a lot of women of color who feel, and we've seen this in anecdotal in stories recently, just how women of color feel unheard and disrespected in their experience with their care providers. So too often, as I said, women of color experience bias and they feel unheard and disrespected. We've seen this example from Serena Williams. You could not have a more powerful and a more healthy and a more privileged woman in a lot of ways who still felt like she was not being listened to and not taken seriously. And her own report of how she felt and how she knew her body and still felt like she wasn't being listened to. So I think that if this happens to Serena Williams, it happens to so many other countless women as well. A lot of these require federal support in order to provide the funding to address some of these models. There are things like the culturally and linguistically appropriate services standard. There is room for additional federal support to make sure that these standards are being implemented, as well as additional support on training and professional development. But I think one thing that I'd like to share is there's a lot of room for local communities to innovate around linking payment to quality. So this is something that can go a long way in helping to improve the quality of care. So in the current system, in the current system, payment from Medicaid is mostly determined by just the quantity of services that an individual receives. But if we adopt these new models of care that focus on preventive care and care coordination, in part by linking payment quality to quality and rewarding high performance, this can be an important tool for reducing maternal and infant mortality. So there's a couple of examples that are cited in the report, but I just want to take a moment to highlight a couple. So again, like this kind of reward structure incentivizes quality over quantity, and especially for some of these high cost, high margin services. And programs like Wisconsin's flip these incentives. So programs like Wisconsin incentivize care coordination and quality of service over quantity of service. Every woman that is part of the system is assigned an OB practitioner, and this practitioner helps ensure that the women get the care that they need. So you have one person in charge ensuring that mom doesn't fall through the cracks. And we've seen good outcomes from this. We see that postpartum cares increase. An increase in postpartum care is linked to just better health outcomes for mom down the road. It also is an opportunity to help catch mental health challenges that the mom might be experiencing. And of course, we know how important this is for infants' long-term, for infants' development and for mom's health as well. Another example that we came across was in North Carolina. So North Carolina has a lot of similar features. In addition to Wisconsin, they also include requirements that moms must be screened for preterm birth. And this is particularly important. Preterm birth is a big driver in racial disparities in infant mortality. It explains about half of the racial disparity between African American and white babies. So if you are screening women for preterm birth and helping connect women to services that help them prevent having an early birth, this can go a long way in reducing racial disparities. And this is also a model that has received some attention because lo and behold, it has actually helped decrease the racial disparity in infant mortality. North Carolina is one of the few states in the United States where we're actually seeing racial disparities in infant mortality decrease. So it's another exciting local innovation. So according to how, and this is sort of the third bucket, according to how we're thinking of this, the stress of experiencing racism and sexism across the lifespan, this plays a significant role in driving poor health outcomes. So in order to address physical health down the road, you absolutely have to address mental health as well. It's important to note, though, that women aren't the only victims here. Maternal and infant mental health go hand in hand. And this goes back really nicely to the concept of relational health that Dr. David Willis discussed in the June 12th webinar. I had a chance to sit in on that webinar and was so interested to see how much synergy and how much overlap there is in these concepts. So if you haven't had a chance to participate in that, I would encourage you to see that. There's a lot of rich discussion there as well. So for those that didn't have a chance to participate, relational health is a multidimensional construct between caregiver and child. And this rich two-sided interaction really builds lifelong health, self-regulation, and resilience. And this lays the cornerstone for all early learning down the road as well. So a lot of the policy recommendations here, you'll see echoes of it in some of this other work as well. Again, much of what is needed here is explained in greater detail in our report and also echoed really nicely in the earlier webinar. But again, much of what is needed is, first of all, greater education around maternal and infant health. I think there's plenty of times that I've spoken to colleagues that are not necessarily in the early childhood community, and I've talked about the concept of infant health, and it is a completely foreign concept. Infants and very young children do display signs of trauma, and they do have mental health considerations that need to be taken into account. And this is a concept that is still really unknown to a lot of people. So in addition to just greater education around this topic, I think we really need promotion, and we need promotion around mental health is an integral part of physical health. They go hand in hand. There's some promising initiatives at the local level. So one example that we came across that was really promising was Charlene McRae's Thrive NYC Mental Health Initiative. So this is a program that helps remove and eliminate some of the stigma around mental health and help people sort of have more of a conversation around mental health and normalize some of the challenges that are associated with bringing home a new infant. In addition to promoting, we also need greater screening for maternal and infant health challenges. This is something that can happen through Medicaid. But in addition to that, some states simply recognize that more can be done, and they've already passed some laws on screening for mental health challenges. So a couple examples, Oregon, Washington State, and most recently, California. California really does appear to be taking a lead on this. Recently, new Governor Gavin Newsom released a state budget that includes significant investments in developmental screening, including screening for adverse childhood experiences and supporting trauma-informed care. I think one thing that was really promising to us as we were doing this work, he also appointed Dr. Nadine Burke-Harris. So Dr. Burke-Harris is a pediatrician and a researcher who's an expert on the impact of adverse childhood experiences and trauma-informed care. He appointed her as the state's first Surgeon General. And so we see this as a really valuable example of leadership in saying that infant and maternal mental health matter. They are a critical part of driving these racial disparities that we see down the road. And in order to address them, we have to in order to address physical health down the road, we really do need to look at trauma and we need to look at mental health early. So we need to do also more to support families before and after birth, and not just from the perspective of helping them meet their mental health needs. The U.S. has a number of programs already in place to help families meet their basic needs, but as many of you know, they're either not well coordinated and they're often underfunded, and they're under attacks from under political attacks to cut budgets. And we know that this just is not the right thing to do. So, in addition to stepping up funding to programs like nutrition and housing assistance, these programs that help families meet their basic needs, we simply need to just make it easier to get these for families to get these services in the first place. And we also need to do more to make these services acceptable and effective by delivering these services through trusted community-based programs that are able to meet families' needs in sensitive, culturally responsive ways. Um, in the current system, getting these services is often time consuming and labor intensive for families. And these are families, again, that are already stretched thin. They're not sleeping. They have this new infant that they have to all of a sudden take care of, additional expenses. And so making the time to run around to different physical locations and different agencies in order to get services is an additional barrier. So we have a couple different ways that we envision making it easier for families to get these services. So the first is investing in community programs that offer these one-stop services. So most often, these are health centers that offer Medicaid-funded family health, early childhood education, job training, and adult education. And to some extent, programs like Mama Toto Village and JJ Way also fall into this umbrella. These programs help connect families to nutrition and housing assistance programs. In addition to these services, things like Head Start can fall under this umbrella, and also community schools in some communities would also fall under this umbrella. In addition to investing in these one-stop service centers, I think simplifying the enrollment process across public benefit programs can go a long way in helping families get services. So this is families basically would fill out one form and then be connected to additional services on the back end. This can help families enroll in multiple programs for which they're eligible. What many communities can do is also significantly investing in home visiting. So home visiting, especially evidence-based home visiting. So these are evidence-based programs that deliver comprehensive family services and care coordination directly in families' homes. And finally, investing in locally driven community-based initiatives. I'm going to focus primarily on the last two here. So in the United States, home visiting remains a targeted intervention. Partly this is because at the moment, there's limited federal funding from MCV, the Maternal Infant Early Childhood Home Visiting Program. And because of this, states have to prioritize target populations. But what remains maybe less well known is that universal home visiting actually has a long history in some other countries. Universal home visiting has been practiced in the United Kingdom for several decades now. And in this model, all families get a visit from a nurse or a midwife who has additional training in public health. In the United States as well, there are a couple places throughout the country that practice universal home visiting, although they each have slightly different approaches. A couple examples here. Welcome Baby. So this is a free voluntary home visiting program designed and implemented for communities in downtown Los Angeles. These programs follow families from pregnancy onward. There's also Family Connects throughout the United States. And we're also really pleased to see that Family Connects and Universal Home Visiting has been expanded in Oregon. So Family Connects provides free home visiting from registered nurses starting at baby's birth. And these universal programs have a couple different advantages. They help, first of all, reduce the stigma that can be associated with more targeted services. And they can also help programs find some of these hard to reach families, families that are in greatest need and can benefit the most from additional supports. And then it takes these families that are hard to reach and connects them to services that are available in the community. And finally, some of these locally driven universal home visiting programs like Welcome Baby, they also are able to reflect the unique cultural and social and political needs of a particular community. Which brings us to supporting and funding local community initiatives. Again, there are lots of examples that we could go through throughout the United States, but we chose to focus on one in Baltimore in particular. So in 2009, about 10 years ago, Baltimore had the fourth highest infant mortality rate among comparable U.S. cities. And Black infants here were dying at 5 times the rate of white infants. After an extensive period of community engagement and analysis of local needs, initiative leaders developed a locally driven initiative to reduce instances of premature birth, low birth weight, and unsafe sleep. And this initiative, which was called Be More for Healthy Babies, focused on a couple different pillars. And again, these pillars were identified through local needs. A few of them were safe sleep, making sure that messages about safe sleep were widespread spread throughout the community. Two, home visiting, increasing home visiting and making sure that families were connected to the services that they needed. And three, parental education. So again, this was a local initiative that was driven through community engagement and really based and grounded on the needs of the specific local community. Finally, the last bucket of policy recommendations around data collection and oversight. Many of us have heard the dictum, I'm sure, that in order to make progress, you have to measure what matters. And this brings us to the last policy area in our report. As the last example demonstrated in Baltimore, having high quality local data helps states and local communities better understand their health landscape. And this is a key part of developing strategies that can succeed in that particular context. States and local communities need to do more to improve the data collection and oversight in order to improve maternal and infant health. But it's simply not the case in many states, sadly. So at the moment, about 13 states still do not have state level review committees. These are called maternal mortality review committees, and these review individual deaths, individual maternal deaths. So 13 states still do not have these committees in place. And also, many states still do not have the equivalent committee to review infant deaths. And some states arguably have too few. In some cases, like Colorado, you have one infant mortality review committee to cover the entire state. So it's arguably just not enough. So luckily, this is one area where we've seen, thankfully, a good amount of federal traction. But we think it's been partly driven by the success at the state level. In the last few years, several states have passed laws that establish some of these review committees, and this has helped give rise to federal legislation that helps states continue to build on this momentum. However, I think that there's still lots of opportunities for states to innovate. And I think a lot of this can be done on helping put a finer point on unpacking the role of bias in driving these disparities. So I think a couple questions that these local review committees can ask and reflect on is thinking through how they're collecting better data on these social determinants of health. How can they collect better data on the role of mental health in driving disparities in maternal and infant health deaths? Better data on the role of racism and other biases in leading to these inequities that we're seeing. I think there's also room for a lot of innovation around linking data from maternal and infant health. We know a lot of times these data are collected in separate systems and they're not necessarily coordinated well. If this is an area of, if this is sort of a newer area of research, and if this is of interest, I encourage you to reach out to your local maternal mortality review committee, or also your infant mortality or fetal infant mortality review committees. So in conclusion, this was a very, very fast, very high-level report, summary of our report. But as you can see, this is an incredibly complicated, multifaceted issue, and this requires action from across a number of policy fronts. But not just that, not just requires policy action across a number of fronts. It will require policy action across all levels of government, including federal policy and also local government. I hope that this is a starting point of a fruitful dialogue, and I look forward to our discussion. Thank you for your time.
Cristina, thank you so much for your very informative presentation and for keeping this topic on our radar. I think you've given all of us, regardless of what role we might play in our work, some ideas to think about how to compel action in the spaces that we live and work. So we really appreciate your talk today. We want to pause and see if there are questions from the participants on the line. We did get a few questions, Cristina, through the chat box. So I think what we'd like to do is see if there are folks on the line that'd like to talk directly with you. And if not, then we'll go ahead and kick you some of those questions. So it looks like there is someone on the line that's ready to talk, and I think you've been unmuted. Can you just state your name and your city and state and go ahead and pose your question?
Hi, can you hear me?
Yes, hi.
This is actually Erin from CSSP, and I'm going to read the question that's in the chat box.
Okay, hi, Erin.
It says, hi from Bridgeport, Connecticut, and our Baby Bundle initiative. We have been working closely with, and of course my computer freezes.
Okay, I can read it.
I got it now. We've been working closely
great.
with our very strong doulas in our community. We have supported the state Medicaid bill to reimburse for doula services. We are making progress. One of the largest barriers we are finding is the unwelcoming environment there is in the clinical sector and hospitals toward doulas. We are looking to do some clinical training. Any suggestions for the best way to tackle this barrier?
Yeah, well, thank you so much for that question. I want to say that this is something that unfortunately, I don't think that you're the only one that is in this situation. I mean, I think continued conversation, I think trying to, again, focus on the ultimate goal, that what you all have the same goal in mind. You want to reduce maternal and infant deaths. And so I think to the extent that you can focus on that goal, and sort of frame this not in terms of us versus you, but just trying to keep that ultimate goal in mind, I think can help potentially get buy-in there.
Great, thank you. We've got another question. The question asks, have you seen any communities where faith-based organizations have taken a role in public awareness regarding this issue?
Yeah, definitely. I'm pretty sure, I'll have to double check, but I'm pretty sure that the example of Baltimore was another place, one of their partners in helping promote some of these parental education and safe sleep initiatives, did partner with the faith community there, and I think that in a lot of places across the United States, engaging with faith-based communities can be a really powerful way to increase education, increase knowledge about resources that are available. So I think that that's definitely an example. And I'm pretty sure that Baltimore is an example of a local initiative that engaged the faith community.
Great. Thank you. Another question reads, do you have any information? So earlier in your presentation, Christina, you talked about some states that don't have the infant review committees. So the question is, do you have any information about states that didn't have review committees but recently got them? And what did it take in those situations to convince decision makers that the mortality review committees were necessary?
Yeah, those are great questions. So I think a good starting place to see where states have mortality review committees and where they don't is by looking up the National Fetal Infant Mortality Review Committee, just Googling around and trying to find that. So that has more information on um, where these committees are in place and and where they're still absent. I mean, I think that there's been a lot of progress, thankfully, on increasing the number of maternal mortality review committees. And I think partly what it took is increased public awareness and increased public attention to this. So we saw that, for example, NPR and ProPublica published a number of series on the lack of these maternal mortality review committees, and how this is such a simple solution, but it's lacking in so many places. And I think that level of public scrutiny and that media attention was instrumental in helping getting state and local governments institute maternal mortality review committees. So I think one potential strategy is just trying to increase public awareness, maybe through more media outreach. I think that was something that really helped on the maternal mortality review front. So I think that could potentially do more to increase awareness around the lack of fetal and infant mortality review committees as well.
Great, thank you for that. Another question came in, says, it sounds like there are opportunities for the federal government to help improve access to care and also opportunities for locals to support or invest in improving access to care. What role can the state play, and how do you suggest that communities work with the state? And
Yeah.
what should they be working towards exactly? And just as just a quick caveat, that question came in before you talked about the I'm tongue-tied here, the Mortality Review Committee. So I think any suggestions outside of that could be helping to answer the question.
Sure, absolutely. So I think one thing that a couple of things that states can do. One, states have the ability to decide whether or not they're going to expand Medicaid. So I think we have seen several studies come out recently showing that states that expanded Medicaid helped see declines in infant mortality, preterm birth, and low weight birth. And in addition, Medicaid expansion helped reduce racial disparities in all of these health outcomes. So I think for states that have not expanded Medicaid, that is an opportunity for action. Second, I think that states also have an opportunity to be a little bit more generous around and think through uh, who is eligible for Medicaid and for how long will they be eligible for Medicaid, and what percentage of the poverty level. So I think those sort of details are also something that a state can work through. And I think this was not covered in this. This was not covered in our discussion here. But we also have a smaller section in the report that talks about other policy areas that are also really promising. So a couple of things are on just increasing and improving supports, economic and work supports for families. So there's also been some research out there showing that things like state paid leave can make an impact on infant health outcomes. So state paid leave is something that is definitely can be implemented at the state level, and also things like state tax credits. So particularly the state earned income tax credit, and also if a state has a child tax credit. So these are all things that can be implemented at the state level. And there's also research just showing that these things improve specifically preterm birth, low weight birth, and all of these things are so closely correlated to infant mortality.
Hi, this is Erin again. I know Dixie Morgese from Volusia and Flagler counties in Florida had a comment. Dixie, did you want to share? Let me make sure she's unmuted. Dixie, did you want to share your comment? All right, and Gussie, did you have any other questions?
Yes, so we had one more question, and it had to do with the trend of infant mortality over time. So, Cristina, the question is, it's clear that the trend has not been static over time, and did you uncover anything in your data any data in your research that showed what exactly contributed to decline in infant mortalities in any pockets of the country? So is there any important lessons learned in terms of what's worked that could be helpful to the audience today?
Yeah, so a couple of things. We saw, so as I mentioned before, Medicaid expansion was a really important piece in this. So like I said, states that expanded Medicaid saw their rates of infant mortality decline more quickly after Medicaid expansion. So that's a big part of it. I think as well, you saw declines in infant mortality and in maternal mortality in states that implemented these maternal and infant mortality review committees. So I think California is a really important example of this. When California implemented its maternal mortality review committee, you saw that the mortality rate declined dramatically. And so I think all of these are good outcomes, and all of these things are sort of patterns that we're seeing that all of these policies can make a significant impact because we're already seeing it. We've already seen that it's been borne out by the literature. I think one thing to keep in mind in all of these things is how important it is to continue to take stock in the impact of these policies and make sure that they're not just reducing maternal and infant mortality, but how well are they also reducing these disparities. And so I think in that sense, like you're seeing things like these pregnancy medical homes that we described earlier. We saw that pregnancy medical homes helped decrease the infant mortality disparity in North Carolina. And we saw, again, in some cases, states that expanded Medicaid, that was also an opportunity to see this. This was also a way that we saw these disparities decrease. So I think it's just, don't rest on your laurels and make sure that you're continuing to analyze make sure that you're continuing to reflect on the data that you're getting, and really dig into not just decreases in overall maternal and infant mortality, but also how well are these policies reducing these disparities.
Great. Thank you so much for that. And so I've got a question of my own, and so I wanted to just circle back to the question that had come in from Bridgeport, Connecticut about the doulas. So my understanding of that question had to do with, just the culture of the hospital or the medical setting not really being ready or really understanding the role that the doulas play. But at the same time, it seems like this is a really important growing response that seems to be working well across the country and in pockets of communities. And so with that growth of the use of doulas and really understanding the ways in which doulas can support women, I wondered if there's something broader or bigger that the Bridgeport community might think about in terms of maybe how to get support from another community that has a growing doula service providers who are doing really great work that might be able to help inform, how Bridgeport might think about supporting their own doula. So are you aware of a broader or bigger movement or organization that that community could tap into for more support?
Yeah, actually, that's thank you for that helpful follow-up question. It's helped me sort of think through something that's maybe hopefully a little bit more helpful. So I think not too far from Bridgeport is New York. New York City has established a pilot program around paying for doula services through Medicaid. And so I know that this is something, from what I remember, it sounds like this is something that Bridgeport is already sort of working through. But I think potentially doulas in New York City might be helpful partners in helping think through how they were able to get, how they were able to engage on this politically and get the help leaders sort of develop the political will and the political courage to take this on. Um, and I would say in that sense, Ancient Song Doula I know was really involved in in promoting this in New York City.
Great, thank you. I've got another question, and it asks, have you studied any telemedicine or telehealth interventions to increase access to care?
Yes, absolutely. So this is also in the report. And if you have any questions about this, I would really encourage you to look at the report. But I think that telehealth and telemedicine definitely can play a really important role in expanding access to critical services. I mean, I think especially in the context of mental health services as well.
Great, thank you. Another question asks, this is from Christella in Washington, D.C., from the Mary Center. Is there any data that represents the quality of healthcare services based on the type of medical insurance patients have?
Yeah. I think some of this is definitely in the report as well. I think partly what we're seeing, and again, this doesn't directly answer the question, but it's closely related. I think part of what we're seeing that is contributing to these racial disparities is just how routinely African American women receive care from lower quality settings. So we see that African American infants are more likely to be admitted to NICUs, neonatal care intensive units, that are lower quality. So even if it's not directly related to the insurance payment, we are seeing these disparities in sort of the quality of healthcare access by location.
Great. And we have one more question that I think we can sneak in. This is from Kelly Levine or Lavin. I'm sorry if I mispronounced your name. The question is, do you see any differences between urban and rural communities in regards to maternal and infant health disparities?
Yeah, those are great questions. So I think, first of all, I think that in terms of maternal health, the data that we have is just such poor quality. The United States has not published an official maternal mortality rate in more than 10 years. So the data that we have on maternal mortality is just, unfortunately, just really poor quality. And so if we don't have that from if we don't have a national level, a national estimate, I think it's difficult to get regional disparities what regional differences in maternal mortality. The data that we have on infant mortality is a little bit better. We have not been able to look into this in very much detail yet, but it's definitely something that we're looking to do in the future. And we're also looking forward to seeing, as states get better data on maternal mortality, we're also interested in doing more digging into this topic and looking at regional differences as well as differences across urbanicity.
Great, and I just wanted to share one comment before we close. Dixie from Healthy Start in Volusia and Flagler County in Florida was having an issue being heard, so I just wanted to share her comment. She harkened back to Baltimore and mentioned that in their work, they made a correlation between low birth weight and housing insecurity, as well as the impact on social determinants of health. And she said that this is a major issue for many women, and thinking about housing as a health-harming legal need, and lawyers could be helpful in this space with regard to advocating for the rights of women.
Absolutely. No, that's...
Go ahead, Cristina.
No, I was just going to say absolutely. I think that that's a really, really insightful and really important comment.
So I know we're at the end of our time together. Cristina, we want to thank you once again for your time, wisdom, and expertise today. In terms of next steps, we'll be sending all of the participants a follow-up note within the next 1 to 2 days. It'll include a link for you to evaluate this survey. It's a survey to evaluate this webinar, and we will also include a recording of the webinar, including the deck of slides. And then, of course, if you have any questions, you can be in touch with me, Ngazi Lawal, or Erin Robinson, or if you have direct questions for Cristina, you may be in touch with her as well, and we'll have all of that information included. So again, thank you so much for your time today, and have a great afternoon.
Thanks.
Thank you.